All right.
All right,
Ready?
we're ready.
Okay. Hello, everybody. Hope you guys are having a great day / evening wherever you're at in this great country and your great state. My name is Stephen Rahm. I'm the Chief of Clinical Direction for the Center for Emergency Health Sciences, and I'm also the center's co-chair. We're located just northeast of San Antonio in the big state of Texas. So we're going to talk about a topic here that is, if you look at Twitter and you follow folks like Dr. Stephen Smith and Amal Mattu and Tom Boothele out of Hilton Head Island, North Carolina, or South Carolina, I'm sorry about that, Tom, about patterns of acute coronary occlusion. And I title this Heart Alert simply because in our region, if we have a patient that needs to go to the cath lab, we don't call it a code Stemi, we call it a heart alert. And I'll elaborate on that. Because there is a difference. And that's why this is going to talk about patterns of acute coronary occlusion, not just STEMIs. So a lot of these are pretty obvious. Some of them are not so obvious. This is just a little montage of our lab and some of the stuff that we do where I work. And just like our little logo says, connecting experience with the future. And it's just an honor to work with a great group of folks that I work with, and just getting up every day and coming to work just makes me very happy. So I just told you that STEMI is not the best term to use. So why are you looking at on the slide? Well, because I'm going to overlay it with this. And this document, I would encourage any paramedic who reads multi-lead EKGs to just Google on the internet, and you can download this. It's free. It's all free open access med education. And Dr. Pendle Myers, one of the co-authors of this OMI manifesto, has a really good video cast where he explains what is referred to as the STEMI in STEMI paradigm. So, and I'll be honest with you, a lot of this stuff when I read is like super scientific and deals with formulas, and my mind doesn't really think that way, but a lot of it is really important, and it's like, that makes sense. So if we go back to, let's say, pre-2000, we weren't using terms like STEMI and NSTEMI. We were calling it either a Q wave infarction or a non-Q wave infarction. And a Q wave infarction meant that you were having what's called a transmural MI. In other words, that injury was extending through all the different layers of your heart, from epicardium through myocardium to endocardium. So if a Q wave infarction was a transmural MI, then what was a non-Q wave infarction? Well, it was referred to as a subendocardial MI. So basically, it did not involve the full thickness of all of the different layers of the heart. And then in 2000, the terms STEMI and NSTEMI came along. So ST elevation myocardial infarction and non-ST elevation myocardial infarction. And that's kind of where we're at right now, but the times are changing where we may not be hearing that as much anymore. And if you're in the Twitter sphere and you follow Dr. Smith, he doesn't use those terms, he uses OMI, and I'll explain. If I was calling in a report to a hospital and I was saying I'm bringing in a STEMI, it would automatically be assumed that I am looking at ST elevation on the EKG, automatically, because that is the very definition of it. So that being said, it is possible to have a false positive. In other words, I can be looking at a pattern that shows ST elevation, and I get the patient to the hospital and it turns out to be something other. Maybe it's benign early repolarization, maybe it's pericarditis, maybe it's just poor lead placement on my part or my crew's part. If that's the case, shame on us. Either way, the cath lab gets canceled, and that will be dubbed a false activation. So it is possible to have a false positive, but in this STEMI and STEMI paradigm, if we're using ST elevation to define a transmural infarct, then one theoretically could not have a false negative, right? Because if there's no ST elevation, then you're not going to call it anyway. So that, hopefully that makes sense, but that kind of puts us into this paradox of, okay, so STEMI is a specific EKG manifestation of acute coronary occlusion. It's but one. But there are other patterns consistent with acute coronary occlusion that would not fit the definition of STEMI. Now, I think pretty much everybody, at least in this country, is still using the ST elevation, the contiguous ST elevation of 1 millimeter or greater in 2 or more contiguous leads in a patient with signs and symptoms of acute coronary syndrome. That's pretty much a universal, automatic cath lab activation. In fact, that is directly from the American Heart Association. However, I can't say that all systems are doing that, because we're going to talk about, and when we talk about bundle branch blocks, we're going to talk about the Scarboza criteria, for example, which there are agencies across the country and regional systems that utilize that in making a determination of whether or not they're going to take somebody to the cath lab. So right now, the terms STEMI and InSTEMI are still the terms of the day. But if you follow the literature and kind of read some of this stuff that's out there, that's changing in a lot of minds of a lot of people. So when you look at this differential of ST elevation, I put acute coronary occlusion at the top just because it's with A. But acute coronary occlusion is not the most common cause of ST elevation on the EKG. There are far more common causes, whether it's just a normal variant ST elevation or what we call benign early repolarization, hyperkalemia. Now, hyperkalemia, if you follow Dr. Amla at EKG Weekly, he calls hyperkalemia the syphilis of EKGs, the great imitator, because one, it always shows up when you don't want it to, that being the syphilis of EKGs, and the great imitator, it can virtually mimic any cardiac dysrhythmia, narrow, wide, slow, fast, with or without AV heart block. But when you start looking at these really, really, really wide, complex tachycardias, man, that should be the first thing on your differential is, what is this patient's potassium, especially if there's an accompanying history of renal insufficiency and taking ACE inhibitors, both of which, of course, are risk factors for hyperkalemia. But nonetheless, that is a common cause of ST elevation. Osborne waves, pericarditis brugata, LVH, bundle branch block, left ventricular aneurysm, all of these are common causes of ST elevation. And just because we see them doesn't automatically mean the patient's having an MI. Let's talk a little coronary artery distribution here for a second. So I'm looking at the image over here on the right, and you can see that right off the ascending aorta, so this would be the ascending aorta, and again, hopefully you can see my mouse cursor. So you have the right coronary artery, and then you have the left coronary artery. So those arteries are literally off the leaflets of the aortic valve. So when the heart contracts and the aortic valve opens, then obviously blood is pushed up into the ascending aorta, the aortic arch, feeds your main arteries, down the thoracic aorta, the abdominal aorta. It's not until that aortic valve closes that blood kind of backwashes down the aorta and fills the coronaries. So your coronary arteries actually fill during diastole. They don't fill during systole. So you've got your right coronary artery coming off the right ascending aorta, and it essentially has two main branches. You have this marginal branch right here. And if you look at the image on the left, this being the posterior, you have this posterior descending artery right here. So, and about, I'd say 85 to 90% of us, we are referred to as what is being right side dominant, which simply means that in about 85 to 90% of us, the posterior descending artery is a branch of the right coronary artery. So about 85 to 90% of us in that regard are right side dominant. The other 10 to 15% are left side dominant, which would mean that the posterior descending artery is actually a branch of the left circumflex. So, which simply means that when you're looking at an inferior STEMI or inferior OMI, occlusive myocardial infarction, by the way, that's what that stands for. I should open that up with that. We're looking at an inferior injury pattern. Most of the time it's caused by a right coronary occlusion. However, there is a certain incidence rate where it's actually a left circumflex occlusion that you're looking at. So you're probably asking, why do I care? You care because there's a big difference between a right coronary occlusion and a left coronary occlusion. With right coronary occlusions, we're worried about bradycardias, we're worried about AV heart blocks, we're worried about right ventricular involvement, which basically makes your patient preload dependent, predisposed to hypotension. We're worried about potentially having to pace that patient. So right coronary occlusion problems produce their own set of problems compared to left coronary occlusion. So going by this image here again on the right, excuse me, you're looking at the left main coronary artery, which comes off the left descending aorta. And this is affectionately referred to as the mother of widowmakers, because your left main coronary artery is going to branch into your LAD, the widowmaker proper as we know it, and the left circumflex artery, which is going to kind of come around and feed the lateral wall and come around and pick up some of that posterior wall. If you follow my mouse cursor down here, I'm coming down the LAD, and you can see how the LAD kind of comes around and wraps back under the inferior wall right here, the inferior wall. So the right ventricle, the inferior wall of the right ventricle is fed by the right coronary artery in the majority of people. But there are some MIs that we see that show elevation, not just in your anterior leads, but elevation in your inferior leads as well. And I do have an example to show you folks here a little bit later on. And what that could be the result of what's called a wraparound LAD. So that LAD is coming down here, it's taking out all the anterior surface, but then it's wrapping around and it's picking up some of that inferior wall, which would then give you ST changes in your inferior leads. So that's a little bit of coronary anatomy. Now, I get it. At the end of the day, they're going to find out where that culprit lesion is in the cardiac cath lab. But I believe that if we're looking at a pattern on an EKG and we know where the ST elevation is, then we should be able to, not with obviously 100% accuracy, because nothing's 100%, at least be able to anticipate what they may very well find in the cardiac cath lab. For example, and this does directly impact your treatment, any patient with an inferior MI pattern, that's an automatic right-sided EKG at an absolute minimum, because about 40 to 45% of inferior wall MIs involve the right ventricle, which means now your patient, if you give them nitroglycerin, you could effectively kill them. And in medicine, that's basically rude, right? The treatment would be volume for those folks. So I'll show you some examples of both right coronaries and left circumflex. And I've got also a really good EKG to show you of right ventricular infarct. I pulled this study up. This was published back in 2013 in Pre-Hospital Emergency Care, 472 paramedic cohort. And they were trying to determine how accurate are we at paramedics and actually identifying these injury patterns in the field. So as you can see with inferior MI, we have a pretty high accuracy rate. About 96% of that 472 paramedics correctly identified an inferior STEMI. Well, that's not surprising because inferior MI is like the bunny slope, right? It has very specific and predictable changes, and both in where its indicative changes are and where its reciprocal changes are. So it's really not surprising that we have a really high degree of accuracy, but you can see that our success goes down when we get into anterior STEMI and lateral STEMI. And then as you can imagine, isolated posterior STEMI, those get missed by physicians all the time. So what did that mean? That meant overall in this particular study of this cohort of paramedics, they were 75% sensitive, which meant that they correctly called an MI 75% of the time. That's the specificity or the true positive rate. I'm sorry, the sensitivity. The specificity, which is the true negative, 53% of the time they correctly said it wasn't an MI, which meant that 47% of the time they incorrectly said it wasn't an MI. So if that makes any sense to you, sensitivity versus specificity. I would like at some point to create a study that's bigger than this. It encompasses several thousand paramedics just to see where we kind of stand. Because this was 7, almost 8 years old, but it kind of gives us a snapshot in terms of how successful we are in being able to identify these in the field. So where do we measure? So if you find your J point is where your QRS, I use that term very generically because this is obviously a QRS because you see it, whoops, my bad. You see a Q wave, you see an R wave, and you see an S wave. So wherever your QRS terminates at your J point, then your J point is going to be put level with your TP segment, which is right here. Now, in many cases, you don't have to use a straight edge because the amount of ST elevation kind of jumps out of the EKG and slaps you on the face. But on some of these very, very subtle MIs where you're looking for right at that 1 millimeter mark, then a straight edge would be very beneficial to you. Again, keeping in mind that patients have MIs all the time with no ST segment elevation at all, which is the biggest case one could build for serial EKGs. Upper example, you see that the ST segment is essentially isoelectric. And when I teach my courses, I usually use the term isoelectric-ish because none of us has a perfectly isoelectric ST segment, and some deviation above or below, as long as it's less than a millimeter, and it's usually less than a millimeter, and it's not in contiguous leads, could very well be a normal variant. It could be a normal pattern for that patient. Of course, it could be lead placement as well. Obviously, these lower two examples, one would not need a straight edge. Here's your J point, here's your TP segment way down here, and there's obviously a monumental amount of ST elevation in this example, as well as a monumental amount of ST depression in this example here on the right. These are classic, these are obvious, and these are easy, but they're not always that easy. So what does the American College of Cardiology and the American Heart Association say right now, as of today, of when we should do a field activation, or when we should call ahead and say, we're pulling the trigger, patient's having an MI? Well, first of all, they have to be having signs and symptoms. And it could be chest pain, pressure, discomfort, shortness of breath, or any anginal equivalent. So when we think of signs and symptoms of ACS, the first thing we think of is chest pain. Well, that is present in the majority of people having ACS, but it's often absent. So to ask yourself, these older folks, especially elderly females, and especially when they have a history of diabetes, they may not present with classic symptoms. That is a classic patient demographic that is going to have very vague symptoms. They're only, or maybe they have unexplained nausea, or maybe they have unexplained diaphoresis. So any kind of complaint in a patient of that age, especially with that history, man, you got to do a 12-lead EKG, because if you don't, you're likely going to miss something. So in the absence of left bundle branch block or left ventricular hypertrophy, and the reason why in the absence of, because ST elevation can be present and actually is present with left bundle branch block, and it's often present with LVH. So those can confound the diagnosis of an underlying STEMI. So those have to be absent. Signs and symptoms of ACS plus ST elevation that's greater than or equal to 2 millimeters in males, or greater than or equal to 1.5 millimeters in females and leads V2 and V3, or ST elevation of 1 millimeter or greater in 2 or more other contiguous leads. This middle component here, a lot of folks may not be aware of, because we just see this and we see this. So maybe you have that patient that has signs and symptoms of ACS, and you're looking at 1 millimeter of ST elevation and leads V2 and V3. Now that would, in most cases, meet your regional agency department's criteria for calling in a code STEMI or a heart alert or a code heart or whatever nomenclature you use. But then you get the patient to the hospital, the cardiologist takes a look at it and says, nope, it's not an MI. That's a normal variant ST elevation. That's when I would seize that opportunity, and I would just ask the docs, hey, first of all, I'm glad they're not having a heart attack. That's good. But two, could you just quickly go over this with me? Because this is what I was seeing, and maybe you can explain to me what you're seeing, or in this case, what you're not seeing. This is how we learn, folks. This is how we learn. Just start a dialogue with them. And I think you'll find that a lot of times they are more than happy to just sit there and just go over that EKG with you real quick. So that way you'll learn to be prepared better for the next one. All right. When you're looking at an area of injury on the EKG that is directly impacted by that event, and I use the mnemonic SALLI, S-A-L-L-I. I think a lot of us use the term I see all leads, inferior, septal, anterior, and lateral. I like SALLI because it breaks down my low and my high lateral leads. I look at those two lead configurations independently of each other, because even though it's not that common, some patients can have an isolated high lateral STEMI, which means they may have some ST elevation and one in AVL, but when you look in the low lateral leads, V5 and V6, there's actually reciprocal ST depression. And I actually have an EKG to show you folks of exactly that. So I always look at V1 and V2 for my septal leads, V2, V3, and V4, my anterior leads. And actually, truth be told, I look at V1, V2, V3, and V4 kind of all in one fell swoop. And the reason why I do is because all of that territory is fed by the LAD anyway. Then I come down there and glance at V5 and V6, and then I look at 1 and AVL, and then finally I look at 2, 3, and AVF. So I'm looking for indicative changes. I'm looking for ST elevation. I'm looking for hyperacute T waves. I'm looking for pathologic Q waves. I'm looking for any indicator of either acute myocardial ischemia or old myocardial damage. Where there's an indicative change. So this slide right here, I love this because this is color. I like dealing with color. So for those of you out here that are colorblind, I apologize. But everything that you see that's colored in green, that's all LED territory. So yes, can people have isolated septal MIs? Absolutely, they do. But more oftentimes than not, they have an anteroseptal MI. So you often see elevation in V1, V2, V3, V4. Nothing wrong with breaking those two leads into V1, V2 independently and then V3, V4. Just my habit is I just look at all in one fell swoop. So anytime you see elevation in those leads, you're usually dealing with an LED occlusion. Then you look at V5 and V6, those are your low lateral leads. And that's either going to be left circumflex or it could be a diagonal branch of the LAD. So if you imagine the LAD coming right down the anterior surface of the heart, you have diagonal feeders that come off of the LAD. And on occasion, one of those diagonals stretches far enough around and picks up the lateral wall. And that would give you a lateral injury pattern. So you can see some ST elevation in those lateral leads. Then I come up and look at my high lateral leads, and then finally I look at 2-3 and AVF. 2-3 and AVF, most of the time when you see ST elevation in those leads, the patient's usually going to have a right coronary occlusion, but in a certain subset, it could be a left circumflex occlusion as well. So what about reciprocal changes? So do you have to have reciprocal changes in order to be having an MI and thus for us to call a code Stemi or heart alert? And the answer is absolutely not. You do not have to have reciprocal changes. In fact, not all anterior MIs, for example, are accompanied by reciprocal changes. Unlike inferior MI, which is almost always accompanied by reciprocal changes. That's why inferior MIs are probably, it's what a lot of people call the bunny slope of MI recognition, because the pattern is so predictable. But just because the patient doesn't have reciprocal changes does not mean they're an automatic rule out. To me, that simply makes a difference between a layup diagnosis and a slam dunk diagnosis, right? If they have ST elevation that's contiguous with chest pain, then I call that a layup diagnosis. But if they have ST elevation with chest pain with reciprocal changes, that's a slam dunk diagnosis. So that's the way I look at it. Take what you will from that. Reciprocal changes, if you use this mnemonic Pails, this helps you. So your posterior is reciprocal with your anterior, which is reciprocal with your inferior and your lateral and your septal, and the whole thing starts all over again. So for example, if I saw ST elevation in V1, V2, V3, V4, I'm going to look down on my inferior leads because that's where I'd expect to see the bulk of my reciprocal changes. If I had inferior ST elevation, then I would look in my lateral leads, specifically my high lateral leads, because that's where I would expect to see ST elevation. So if you remember Sally, that's just an organized way of looking through a 12 lead. And then remember Pails, if you see indicative changes, then that'll help guide you to look for the indicative changes in those particular leads. I think one of the most important things that I've ever learned from Dr. Stephen Smith, and Dr. Smith runs his own EKG blog. The man he's a genius. He really is in EKGs. An EM physician, just has a penchant from multi-lead ECG. But he published this a while back, and that's when I first read it. He could have published it many, many years ago. But what they found on cardiac stress testing was that when the myocardium becomes ischemic, your 12-lead EKG does not localize that like it does injury. Well, let me explain. So if you're having an MI, and let's say it's an inferior wall MI, you would expect there to be very specific leads in which you see ST elevation, like 2-3 and AVF. In other words, it's localizing injury to those particular leads. The same thing cannot be said about ischemia. So that means, and we've all run these EKGs before, where the computer diagnosis, which I will tell you, gets fooled all the time. We should not be using a computer exclusive diagnosis. We can use it to aid our interpretation, but we need to use our own mad skills at being able to finesse and navigate that EKG on our own. Oftentimes that machine will say something like non-specific STT wave abnormality, consider inferior ischemia. That is a misnomer. Your 12 lead cannot localize ischemia in a particular lead configuration, which means that when your heart is ischemic, you're going to see ST depression everywhere. So how did they figure that out? During cardiac stress testing. That's one of the things that your cardiologist does not want to see. When you start developing widespread or diffuse ST segment depressions, it's at that point they're usually going to say, okay, you can go ahead and stop. And oftentimes at that point, you're probably complaining of chest pain. So in that regard, the stress test and the 12 lead will show diffuse ST depression. So when you see localized ST depression, that in your mind is a reciprocal change to something. So if you use that little Pails mnemonic that we just talked about, say, well, I see some ST depression in 2-3 and AVF, and I know that that's reciprocal with my high lateral leads, I'm going to look for some ST elevation in leads 1 and AVL. So the machine cannot localize ischemia, it localizes injury. If you saw ST depression that was localized in your right precordial leads, which are leads V1, V2, and V3, then you should be getting a posterior EKG. Because on a standard 12 lead, there is no lead configuration that looks directly at the posterior wall. So we'd have to use our anterior leads as a surrogate to look for reciprocal changes. All right, so let's look at this first EKG. Excuse me. So if you look at, and we're going to ignore this. Okay, congratulations, computer. You want a cookie? You called it right. That's fine. But you can see some obvious ST elevation down here in 3 and AVF. Now, when elevation more closely, more elevation in lead 3 than there is in lead 2. And when you see that, when you notice that there's more elevation in 3 than there is in lead 2, that is leaning you towards a right coronary artery occlusion. Reason being is because in an RCA occlusion, the majority of vector of ST elevation shifts down to lead 3, which is a rightward lead, right? So when you ST elevation that's greater in lead 3 than it is in lead 2, then you should suspect a right coronary occlusion. But that's really not the slam dunk. The slam dunk is this lead right here, lead AVL. And this is where inferior STEMI is the obvious ones. Bam, you pick them up, it's like that's a right coronary occlusion. If it's an RCA occlusion, you'll see more elevation in lead 3 than you will in lead 2, and you'll see reciprocal ST depression in lead AVL. Now, leads 1 and AVL are your proper reciprocal leads to your inferior leads, but AVL is a more sensitive reciprocal lead. And honestly speaking, I don't even look at lead 1 in an inferior wall MI because I know I'm going to see the majority of reciprocal change in lead AVL, just like you see on this tracing right here. I mean, there's maybe a hint. Maybe I could hallucinate a little bit of ST depression here. I don't know, but there's very obvious ST depression here in lead AVL. So when you see an inferior MI pattern, there's elevation in 2, 3, and AVF, and there's greater elevation in 3 than there is in 2, and there's reciprocal ST depression in AVL, then that's a right coronary occlusion, and that's exactly what was found on cardiac cath. This patient fortunately did well. All of these EKGs, with the exception of just a couple of them, are EKGs that either I acquired on patients or that were acquired in our agency. Now, when you look at this one, you're like, oh, this one looks ugly. Well, yeah, it's ugly because the patient's having a heart attack. It looks ugly because there's a lot more ST elevation, and you're also starting to see some ST depression here in these right precordial leads. So if we kind of methodically break this down, if we look, we can clearly see a lot of elevation in 2, 3, and AVF. But if you look at lead 3, there's arguably more elevation in lead 3 than there is in lead 2. And when you look at lead AVL, there's marked ST segment depression, even more so than there is in lead 1. So just that one finding, inferior MI pattern, greater elevation in 3 than there is in 2, reciprocal ST depression in AVL, I'm thinking this is a right coronary artery occlusion. But then I see this troubling finding right here. You're also seeing some ST elevation out here laterally. So this very well could be an inferolateral MI. But I'm going to focus on this for a second, because going by what Dr. Smith and his folks have published and have proven that the machine can't localize ischemia, this would not be an isolated pattern of anterior ischemia. This is reciprocal to something. It's either reciprocal to this inferior MI or there's infero-posterior involvement, which means in addition to doing a right-sided EKG, which is simply taking V4, putting it on the right side in its mirror image and relabeling it V4R, I'm going to take V4, put it on the right, and I'm going to take V5 and V6 and move them around to the back and convert those to leads V8 and V9. Now I've got what's called a 15 lead ECG, and I'm going to run that tracing again. So that way V4R is looking at the right ventricle because that's my diagnostic lead, V4R. V8 and V9 are looking at the posterior wall. And then the entire far right column of this EKG goes from V4R to V4R, V8, and V9. So it takes two separate tracings, but you get 15 total views, 12 from your base view, and then 3 additional views with your 15 lead. So we see more elevation in 3 than we do in 2. We see reciprocal depression in AVL. We see some reciprocal depression in V1, V2, V3. And this patient had, you can tell, a very obvious, very gnarly right coronary artery occlusion, fortunately, with a very good outcome. Here's another example of right coronary occlusion. So again, when you look at the elevation in 2 and 3, you can see there's elevation in 3 than there is in 2 by perhaps as much as 1 to 2 millimeters. But look at lead AVL compared to lead 1. Now, granted, there's some depression in both of those leads, but look how much more there is in lead AVL. So AVL is your money, it is. And oftentimes you may see ST depression in AVL before you even see any ST elevation in 2, 3, and AVF. So that's where, I mean, we can pick up and you catch more flies in honey than you do with vinegar. If you look at lead AVL and AVL is changing, and I've got some really good transitional slides to prove that point to you, this is where we can pick up those subtle early inferior wall MIs. But nonetheless, this is also a right coronary occlusion, but in this particular patient, it's the posterior descending artery. Remember, 85 to 90% of us are right side dominant. So this was a right coronary occlusion, but it was further down and it took out the posterior descending artery. So if I remove this for just a second, you notice up here, it says this was the left-sided ECG. I apologize profusely. I don't have the 15 lead. I've looked up and down for the 15 lead I did on this patient. I can tell you that there was RV involvement. There was elevation in V4R, but the posterior leads looked fine. There was no ST elevation in V5, V6, or what became V8 and V9. But nonetheless, this patient had a PDA occlusion, also ended up doing fine. Excuse me. Here's another right coronary occlusion. And this just, I always find this comical. I mean, some of the things that these computers say is just downright funny. Demand atrial, I mean, I'm sorry, I don't see that anywhere. I don't see any pacer spikes anywhere. And, you know, sometimes I'm convinced that there's some retired cardiologist that has become a miniature version of him or herself that's embedded in your life pack or your Zoll or your HP or whatever, and they're typing in these computer diagnoses, you know? I mean, don't use a computer and don't take it at face value, because if you do, you're gonna miss stuff and you're also gonna overcall stuff. So we have the mad skills to be able to finesse our way through these EKGs. So let's ignore what that computer's saying for a second. Let's look at 2, 3, and AVF. Now, if I look at lead 2, I can appreciate somewhere between 0.5 and 1 millimeter of ST elevation. But look down here at lead 3, this huge hyperacute T wave. Now your QRS in this particular example is right here. That QRS is all of about 1 to 2 millimeters tall. So you have a tiny, tiny QRS complex. In fact, when your QRS complex amplitude is less than 5 millimeters, then you need to look really, really closely, because using the rule of proportionality, that T wave is clearly way too big. And you can obviously see some J point elevation down here in lead 3, right where my mouse arrow is pointing. And there's obviously some ST elevation here in AVF as well. But if I go back and I look at the elevation in lead 3 and I compare that to the elevation in lead 2, there's more elevation in lead 3 than there is in lead 2. And if I go up here to my money lead and look at lead AVL, there's that reciprocal ST depression. So this is telling me this is a right coronary. I'm suspicious for a right coronary artery occlusion. I also see some reciprocal ST depression out here in V1, V2, and V3. Now look at it. I'll give the computer kudos here. It's using anterior ST depression and reciprocal. So good for it, because that's exactly what that is. It's a reciprocal change. That is not isolated anterior ischemia. So what did the cath image show on this? Showed 100% right coronary occlusion, completely stumped it off right here, and then that patient was able to be reperfused. Look at the age, 48. Now I'm 53. So when I look at EKG tracings like this of anybody who's younger than me, I always shift in my seat. So this could be any one of us. This was a 48-year-old guy, did not take care of himself. I'm sure most of you do. This guy weighed every bit about 400 pounds. And, you know, I'm pretty sure if he broke his leg, gravy would have poured out or something like that. So he didn't take care of himself, but he got a second leash on life because he had early recognition, he had timely cath lab activation, he had a good interventionalist, and all the stars just kind of lined up for him. So good patient outcome. This one, not so obvious. So the machine is using that word borderline. What does that mean? What does borderline mean? That is computer lingo for I'm confused. That's computer lingo for, I don't know that it's normal, but I don't know that it's abnormal. So I completely disregard the word borderline. It means nothing to me. It's also using another word. It's using the word non-specific. So it's saying that there's some abnormality in the lateral and inferior T waves, but the machine doesn't know why they're abnormal. So it's using the word non-specific. I don't think that there's any such thing as a non-specific EKG. I think there is very much a thing as a non-specific ECG interpreter, if that makes sense to you. So when you see that, it's like, okay, so clearly the machine is trying to tell me something. It just doesn't know how to interpret the abnormality it's seeing. So if we come out here and we look down here, we have some abnormal T waves in V5 and V6. And if we look in 2, 3, and AVF, we have flipped T waves on a normal 12 lead in which your patient would have inverted T waves. Those leads is AVR, because everything in lead AVR is naturally inverted because that camera, that lead, always sees the electrical impulses going away from it, which means AVR should always be negative. The other lead in which you're allowed to have inverted T waves is lead V1. Now, it's perfectly normal to have an upright T wave in V1, such as the patient in this example, but if the T waves are inverted in lead V1, that's also normal. Aside of those two leads, you're really not allowed inverted T waves in any other lead. So this machine, this inverted T wave is telling you something. You don't see hardly any ST segment elevation at all. But if you look in your money lead, you see some ST depression, and that's telling you something. So could I call a code heart or a Stemi alert or whatever just from this one EKG? And the answer is no. This would not meet our regional heart alert criteria, which means I would have to do serial EKGs, and I'm going to pay particular attention to lead AVL. If I start to see increasing depression in AVL, that's an evolving inferior STEMI right in front of me, whether I see ST elevation in 2, 3, and AVF or not. As it were, if you look down here in this complex right here, and the baseline's a little bit wavy, but there is some J point elevation there. This is just a very subtle inferior STEMI. Those are actually the indicative changes. What's circled in the blue is a reciprocal change, 100% right coronary artery occlusion. So I know that a lot of us would have missed this one in the field, whether it's because we just read the computer. I've literally had people tell me, well, I was always told that computer is like 100% sensitive and it's really, really smart. And you should probably go whatever, it's going to trump whatever you read. That could not be further from the truth, and that's dangerous, okay? So we would either miss it because of that reason, or we miss it because we just didn't know where to look. But nonetheless, this was a 100% right coronary occlusion in a 58-year-old, and in this case, a 58-year-old female. This one, the machine is not providing any help, and that's okay. And to lesser minds, this would be a problem. It's not a problem for us. It's giving us the ECG override. Data quality prohibits interpretation. Well, you know what? It says that. Why don't you try to fix the leads, figure out why it's saying that, and run the tracing again? In this case, they did that 2 times. And on the second time, it still gave them that. And they're like, okay, that's fine, because I'm not going to look at that anyway. I'm just going to look for what I know to look for. And this patient was, actually, this patient's complaint was nausea, vomiting, and diarrhea in the middle of flu season. So obviously, a presumptive diagnosis is you got the flu. But that's not what this guy was having at all. He had no chest pain, but you see he's very bradycardic. And if you look around this EKG, you don't see any P waves anywhere. So he's bradycardic. These that you see right here are ventricular escape complexes. Here's a ventricular escape complex right here. Those aren't PVCs per se. They're coming from the ventricles, but they're actually escape complexes to try to compensate for this inherently slow rate. So he's bradycardic. He's not even in a sinus rhythm anymore. Excuse me. And you see some elevation in 2, 3, and AVF. Well, if you look a little closer, you look at that complex in lead 3 and measure the amount of elevation compared to lead 2. There's more elevation in lead 3 than there is in lead 2. And when you go to your money lead, there's some obvious ST depression in lead AVL. Look at this little complex up here in lead 1. It's pretty much telling you there's no ST depression at all. So this is one of the reasons why I don't even look at lead 1. I just look at lead AVL. And this guy had a proximal right coronary artery occlusion. So a proximal RCA occlusion, which means obviously higher up, closer towards the origin of the right coronary, those are the ones that are notorious for taking out the SA nodal artery, the right ventricle, and the AV nodal artery, which makes for a hypotensive, bradycardic, hemodynamically unstable patient that may very well have an AV heart block. So yes, clearly this man needs to go to the cardiac cath lab, but in the field, he was hemodynamically unstable. He had a blood pressure of 60 systolic. So they tried a little bit of fluid and then they paced him. So they're able to get good electrical and mechanical capture. They hemodynamically stabilized him at a systolic BP of about 94, 96. But all of that instability was caused by that proximal RCA occlusion. So that's why it's important to look and see where this injury pattern is occurring on the EKG, because when your patient starts getting sick, then clinically, electrocardiographically, it starts making more sense. This is one that I got, actually, one of the more recent ones. This is actually almost 2 years ago, or a little over 2 years ago. 54-year-old male, so I'm 53, so again, I'm shifting in my seat, presents with chest pain, calls EMS, and he had actually had a history of stent placement before, and you can see that if you look down here in lead 3, you see these pathologic Q waves right here. But nonetheless, so he did have some history, and now he's complaining of chest pain. So they run the EKG, and they see elevation in 2, 3, and AVF. But if you look closely, you actually see more elevation in 2 than you do in lead 3. It's not the other way around like you would expect to see for a right coronary artery occlusion. Look at your money lead though. Look at AVL. I mean, I literally do not see anything other than a perfectly isoelectric ST segment. There is no ST depression in my money lead. So when I couple that with there's greater elevation in 2 than there is in lead 3, that would lean me away from a right coronary occlusion and more towards a left circumflex occlusion. So this gentleman was actually a left dominant patient. He presented with an inferior MI, but it was actually caused by a left circumflex occlusion. So what does that mean to us? How does that translate to our treatment? Well, one, I think we'd all agree we're still going to do a right-sided EKG. And that's good practice. If there's an inferior injury pattern, then we should be doing a right-sided EKG on these patients, period. But you would not have seen any ST changes in V4R because the right coronary was not the culprit artery. The culprit artery was left circumflex. Some of these, you can imagine, get a little bit challenging, and it's like, you know what? I know you're having an MI. I'm going to take care of your pain if I can safely do so. I'm going to give you aspirin. I'm going to get you to the hospital. They will unplug that coronary artery, and they're going to find it anyway. I don't want you to think I'm disillusioning you into thinking that we can call these occlusions 100% of the time. But if we just look at where the pattern of injury is and we look for these little key findings, then sometimes that kind of helps us along a little bit, because there are different treatment needs for right coronary occlusions versus left. All right, this EKG, this is hospital acquired, but this was a patient that our agency took care of a couple of years ago. It was an 84-year-old man who presented in cardiac arrest, and it took our team about 20 minutes to get ROSC on him. So, you know, right off the bat, you're thinking, man, an older man, 20 minutes to ROSC. I think we can see where this train was going. And unfortunately, he did pass away. But we were able to learn some things from this. So he has a lot of ectopies, having, you know, some PVCs and little runs of ETAC. But if I look here at 2, 3, and AVF, I can see some very clear ST elevation here. But again, when I look at 2 versus 3, I see more elevation, and these are PVCs right here. When I see more elevation in 2 than I do in lead 3. And when I come up here to look at my money lead AVL, I see huge ST elevation as well as in lead 1. So you're thinking, oh, okay, so this is left circumflex occlusion. Well, in this gentleman's case, he actually had 2. He had a left circumflex occlusion, which is you're looking at right up here, and then he had a right coronary occlusion, which is what you're looking at down here. So they were able to recanalize those, reperfuse them, admitted him to the ICU. He arrested again, and at that point, his wife, God bless her, she said, just let the man rest. So this guy actually had double vessel disease. What about those patients where there's right ventricular involvement? So I think at this point, we all agree, if there's an inferior MI pattern, at a minimum, we should be doing a right-sided EKG to look for evidence of elevation in V4R. And obviously, you're letting your patient's hemodynamics talk to you. If they're hypotensive with an inferior wall MI, they're not going to get nitroglycerin anyway. And we're going to be very careful with these folks. We're going to give them volume. But when the right ventricle specifically is affected or involved, which is more common with proximal RCA occlusions, then nitroglycerin is off the table. And I've had discussions with folks about this before, like, well, you know, even if there is some right ventricular involvement and their blood pressure is okay, then I give them a little nitro. I'm like, I wouldn't. Why would you give a preload reducing drug to a patient who's preload dependent? I would want to give them more preload to help push more blood from the right side of the heart to the left side of the heart, because our patients did not call us to crater their blood pressure and kill them, my friends. That's just rude. That's not what we do. So how about we just don't give nitroglycerin if there's any evidence of RV involvement? And I will always defer to the American Heart Association, and they say, and I quote, nitrates are contraindicated in the setting of right ventricular involvement. I'm not going to tell you to usurp your protocols and go against what your medical director is telling you. I'm just telling you what the literature says. I'm telling you what our medical director in our region says, and I'm telling you what common sense and reasonable judgment says. No nitroglycerin. But anyway, I think we agree we're looking at a right coronary occlusion pattern here because there's more elevation in lead 3 than there is in lead 2. There's reciprocal ST depression in AVL. There's some right precordial ST depression, specifically in V1 and V2. So in this particular patient, I opted to do a 15-lead ECG. So the next tracing, you'll see V4R, there's 1 meter of elevation in R. V8 and V9, which are my posterior leads, aren't really showing anything. So as it were, this patient did have some RV involvement. Now, how much elevation is too much when you're looking in your modified leads? So 0.5 millimeters. You don't even need to see a full millimeter in V4R or V8 and V9. The threshold is a 0.5 millimeter or greater, which this patient clearly meets. Now, she presented with no chest pain. She presented with a marginal blood pressure of about 102, 104 systolic. She wasn't having pain. I gave her some aspirin, didn't have to give her any analgesia. I just gave her about 750 cc's of fluid, kind of maintained her blood pressure, but she had a very proximal RCA occlusion, completely stumped off way up here. So right off here, you're seeing the SA nodal artery. And then down here, you're seeing the AV nodal artery. Well, yeah, she took out all of those. It's a wonder this woman was still even in a sinus rhythm with all of that. But nonetheless, it was a pretty good example of right ventricular involvement. All right, so now we're going to shift from the right side to the left side. So if you look at the tracing here, leads V1, V2, V3, V4, you see some very clear ST elevation, huge hyperacute T waves in V2, V3, and V4. So I'm looking at a pattern of LAD occlusion. So if I follow Pails, anterior is reciprocal with inferior. So if I look at 3 in AVF, 2 of my 3 inferior leads, I see some reciprocal ST depression. I don't have to see that down there. If these were all perfectly isoelectric, that would not sway me away from this is a pattern of LAD occlusion, which is exactly what the cardiac cath showed. So why am I concerned about this patient? Well, first and foremost, any patient having an MI can fibrillate just like that. So I think it's good medical practice. If you are dealing with a patient who's having an MI, put your R2 pads on them or your defib pads or multi-pads. They go by a lot of different names because these folks have a tendency to suddenly fibrillate on you. You have to ask yourself, if they suddenly fibrillate, where do I want my pads? Do I want them on the patient or do I want them tucked in my monitor? If the patient asks you, what are you putting those big pads on? Just say, I want to get a bigger picture of your heart. That's all. I mean, don't tell them you mean to just shock them, but just, hey, forewarned is forearmed. People do have the tendency to fibrillate. Here's another LAD occlusion in the setting of not just a right bundle branch block, but a left anterior hemi block. So, and we'll talk about bundle branch blocks in my other presentation that I'm giving. But if you look at V1, V2, V3, V4, you see marked ST segment elevation. You come down here and look at all of your inferior leads, 2, 3, and AVF. You have some very well formed ST depressions. Those are your reciprocal changes. It's also a completely stumped off proximal LAD. So if you look at this angiogram right here, and by no means am I an angiography expert, but this is the left main coronary artery right here, and this is the circumflex. So we completely stumped off the LAD right here. You do not, there are two arteries in your body you do not want to throw a clot in. I mean, I don't want to throw a clot in any artery, but if I had my choice of which 2 I don't want, in this order, 1 would be the left main coronary artery. You take out the left main coronary artery, you kill your circ and your LAD, which means you effectively kill the anterior, lateral, and a good chunk of the posterior part of the heart, which is often not a survivable event. So that's one part of the body I don't want to throw a clot in. The other one is my pulmonary trunk. I don't want to throw a clot in the biggest pulmonary artery because now I'm not oxygenating and I'm not perfusing. So this was getting a little bit close for comfort in this patient, right? It was a proximal LAD occlusion. This guy actually did fine. He had 75 cats, would not go to the hospital until every one of those cats were accounted for. And it was mind numbing because we're chasing cats, literally. Here's another pattern of LAD occlusion. Look at V1, V2, V3, out here in V4, huge hyperacute T waves, big ST elevation, and then predictable ST depression down here in 2, 3, and AVF, also LAD occlusion, not as proximal as the other one, but LAD occlusion nonetheless. This is that wraparound LAD that I was talking to you folks about earlier. So if you look, you see some elevation in V2, V3, V4, V5, V6. So you're thinking, okay, so there's evidence of LAD occlusion, but if you come down here and look at 2, 3, and AVF, there's elevation out there as well. So this is actually not a right coronary artery occlusion. This is actually what's called a type 3 wraparound LAD. And that little graphic I showed you, just imagine that guy's LAD, and not everybody's LAD wraps around under the inferior wall. That just, in some patients, he just happened to be one of those patients where an extension of that LAD wrapped around underneath the inferior wall. This is not the best cath picture pre and post, but it's the one they sent me. It's the best one that I had. You just imagine that LED kind of wrapping around the inferior wall. Here's the isolated high lateral STEMI that I was talking to you about earlier. So if you look here, you see a lot of ST depression. So we see ST depression in 2, 3, AVF, V5, and V6. But we don't really see any giant ST segment elevation. So, okay, so I'm like, handshake to your computer, you're calling it an MI, so why would I call it an MI? Well, if I remember, the machine can't localize ischemia. It localizes injury, but not ischemia. So all of these ST depressions that you're seeing are reciprocal changes. If you look at lead AVL, and I'm going to blow it up for you here a little bit, there is about 1 to 1.5 millimeters of J-point elevation, and that T wave is hyperacute. That T wave is almost just as tall as the R wave is, and that is not a normal T wave. So this, I'm going to back up. This is a very subtle high lateral STEMI, in which the majority of ST depression shifted to the high lateral leads, which is why you have reciprocal depression in your low lateral leads as well as your inferior leads, because all of those leads are down and the MI is actually confined to the high lateral part of the left ventricle. Here's another lateral STEMI. You see some ST depression in 3 and AVF. This one's a little bit more obvious. You see some elevation out here in 1 and AVL. Also a left circumflex artery occlusion. Remember, the circumflex supplies the lateral wall and sometimes wraps around, oftentimes feeds a good portion of the posterior wall as well. This one's an isolated posterior STEMI. So I'm going to circle this right precordial ST depression. And just remember, the machine doesn't localize ischemia. So this is not localized anterior ischemia. This is reciprocal to something. Well, if I look out here in 2, 3, and AVF, I don't see any evidence of ST elevation in my inferior lead. So I'm thinking, well, I'm not thinking an inferior MI. So if it's not that, what else could it be? Well, it's reciprocal ST depression to what you would see if you looked in leads V7, 8, and 9, which is a pure posterior EKG, which unfortunately I don't have of this tracing. You'll have to take my word. This was an isolated posterior STEMI, a 3.3% occurrence. So these are rare. Isolated posterior STEMIs, most of them occur in the context of an inferior STEMI. So you actually have an infero-posterior wall MI. Here's another example of a posterior MI. You have some ST depression in V1, V2, and V3, but there's no ST elevation anywhere else. But the next, I'm going to kind of put a little overlay here of the posterior leads of V7, V8, and V9 of this same patient. Remember, the threshold is only a 0.5 millimeter or greater. So there's clearly a 0.5 millimeter, clearly a 0.5 millimeter, clearly it's about full millimeter to millimeter and a half. So this patient, this is confirming that all of this is reciprocal to all of this and vice versa. So when you see right precordial ST depression, get a posterior EKG, because your EKG in a standard configuration doesn't look at the posterior wall. Why do serial EKGs? This machine's telling you this is a sinus rhythm, nothing to worry about. Probably get a signed refusal from this patient. Well, the paramedic running this EKG, which was not me, was far smarter than that and said, you know what, that T wave, those T waves in V2 and V3 are not normal, and was able to convince this 78-year-old woman to go to the hospital. If this woman had refused transport, he would have never had the opportunity to snatch this EKG that was recorded 17 minutes later. So she went from this to this, from this to this in 17 minutes. So now you can see very obvious ST elevations in V1, V2, V3, hyperacute T waves in V1, V2, V3, V4, even extending a little bit out into V5 with some reciprocal ST depression down there in 3 and AVF. Here's another one. This was sent to me by a friend in Connecticut. This man actually did fibrillate in the back of the ambulance. The machine is again saying that's using borderline and non-specific. But if you look down here at lead V3, there's very obvious J point elevation. Look out here in V4, there's very obvious J point elevation, big hyperacute T waves, and the machine missed it completely. How can the machine miss something like this? I don't know. But it didn't miss this, which was also 17 minutes later. So we went from this to this in a matter of 17 minutes. If you just do a single 12-lead EKG, you're going to miss between 15 and 20% of MIs, and that's found in literature. Here's another example. The machine's telling you this is normal. No, this is not normal. This is clearly a hyperacute T wave. There's very obvious ST elevation in V3 and V4, but the machine is saying, don't worry about it. There's nothing wrong. But sometimes it takes the machine to get some compelling evidence like this to be able to pull the little trigger and say, okay, yeah, we'll call it, says it meets MI criteria. Don't wait for the machine to get to that point. Look for the subtle changes. Here's one. This is going to be a transition of EKGs. I want you to focus on lead AVL. Okay, so this is telling me a normal sinus rhythm. It's like, okay, I would tend to agree with that. Anything it's jumping at. So look at the next EKG. Focus on AVL. One. Look at lead AVL. I'm going to go back to the first one. Now you can see that AVL's ST depression is more downsloping than it was in the previous one. That is a change, and that is a noteworthy change. If the second EKG looked just like this, looked just like that one, then I've really learned nothing. But that ST segment is changing. The next EKG, I can look at it in this lead, or in this, now look at it now. So it's getting even more obvious. So your money lead, your reciprocal lead is talking to you. It's telling you that there's something evolving. And if you look at 2, 3, and AVF, there's really no appreciable ST elevation. So now we go from this to this, and from this to this. Now it finally meets the EKG's criteria and says, oh yes, the patient's having an MI. Well, you should have figured that out from the second one when you noticed AVL's ST depression was continuing to get worse. Don't let it get to this point. So just do serial 12 leads, and it just continues to evolve and evolve and evolve, okay? Here's another one. This is the patient. Unfortunately, this was not a good outcome. This man ended up dying in the cath lab from just profound cardiogenic shock. The first EKG is showing some non-specific changes. I'm just going to kind of go through this, and you can actually see how this has evolved. This is not a PVC, by the way. This is just some artifact. So you can see how this is evolving. I want you to pay attention to leads V1, V2, V3, and V4 as we go along here. So we're walking this is 12 lead 4, 12 lead 5, 12 lead BAM. It's not saying atrial fibrillation, it's saying demand pacing, all kinds of garbage that I totally disregard. And now it goes to this, okay? And then it goes to this. So this man went from a seemingly normal EKG, and all of these were in the field. And the difference between this EKG, this was 11:36, and this one is 2 minutes. So in a matter of 2 minutes, the patient deteriorated to this, and then ultimately to this. And this was an extensive infarct. And unfortunately, the man did not have a good outcome. He did not leave the cardiac cath lab alive. Here was that study I was telling you about. There are others out there like it. In this cohort, 334 patients diagnosed with MI. 85% of those were diagnosed on the first tracing. 15% were not picked up until subsequent tracings, which means that we need to be getting serial EKGs. I said this earlier, if the patient's having an MI, put the defib pads on them because they tend to misbehave and fibrillate, and you want to shock them right back out of it like our paramedic did here, got the patient back, and this is 100% right coronary artery occlusion. All right, a couple of things I want to go through here real quickly. I know I've probably gone over my time, and if I have, I apologize. A couple of things that are considered to be, this would not be considered a STEMI equivalent, but it's telling you there's something going on with the patient. It's called Wellen syndrome. It's an EKG that indicates LAD disease. These patients don't necessarily automatically go to the cath lab. Sometimes they watch them. But when you see this pattern, you often see it when the patient is not complaining of pain. So they have a history of chest pain, but by the time you get to them, their pain's resolved. And the abnormality here with Wellen syndrome is not in the ST segment, it's in the T waves. So type A Wellen's T waves are biphasic. They're positive and they're negative. And that's seen in about 25% of cases. More commonly, you see these deep symmetrically inverted T waves or type B Wellens T waves. It's just telling you that this is a reperfusion T wave. So the patient kind of has a spontaneously reperfusing really, really dirty LAD. So this is type A Wellens T waves. If you look at the T waves in V1, V2, and V3, you can see how they're biphasic. They're positive and then they're negative. They're positive and then negative, positive and then negative. If you look at this T wave out here in V4, this is starting to become more like Wellens type B, where it's becoming very symmetrical and deeply inverted. And here's a really good example of type B Wellens syndrome, where these T waves are very deep and symmetrically inverted, but there's no ST elevation on here at all. So this would not meet our area or region's heart alert criteria, and it often doesn't meet many others, but this is worthy of at least letting the facility know that you're seeing this pattern on the EKG. Another pattern, this is called De Winter STT waves. About 2% of LAD occlusions, proximal LAD occlusions, may present with this pattern. And this is where, again, where serial 12 leads are really, really important. So initially, you see some ST depression that just rockets up into this big hyperacute T wave. Now, unlike Wellens syndrome, these changes are very dynamic. So if you don't see ST elevation initially, just keep running EKGs. Now, clearly, you're not going to withhold care or delay transport just to get more and more EKGs. So this is assuming we're doing these en route to the hospital in addition to the treatment that we're doing. So here's a good example of a De Winter pattern. You see the ST depression right here, and you see it just rocket up into these big, big hyperacute T waves. And then the patient deteriorates from this to now transitions to ST elevation and a full-blown LAD occlusion. Last pattern here, this pattern of ST elevation and lead AVR and diffuse ST segment depression. So AVR it's often referred to as a Rodney Dangerfield lead. It doesn't get any respect because we used to completely blow that lead off, totally. There's diagnostic value in lead AVR. So when you see ST elevation and lead AVR and multiple leads with ST depression, then you're looking at something. It's often difficult to put your finger on it. So I categorize them as being heart sick and not heart sick. So if they're sick with signs and symptoms of ACS, and it's typically going to be one of those three that you're looking at, either a left main coronary insufficiency, not occlusion, left main insufficiency, or it could be triple vessel disease, which means you have a dirty right coronary, dirty left circumflex, dirty LAD, or it could be a proximal LAD occlusion. If your patient is sick but doesn't have signs and symptoms of ACS, then it could be any one of what you're looking at. It could be GI bleeding, it could be anemic, it could be a thoracic aortic dissection, or of course there's the syphilis of EKGs, it could be hyperkalemia. So this is what that pattern looks like. So we see some elevation up PVR, but that have ST segment depression. This is one where you have to go by signs and symptoms. So if this guy were having chest pain and he's diaphoretic at a minimum, I would say this is an acute coronary syndrome, but they're ultimately not going to find out where that problem is till they get the patient to the cath lab, because this doesn't localize, right? Because we know that the machine doesn't localize ischemia. This is what true subendocardial global ischemia looks. Here's another example. It's a 42-year-old firefighter that came into the emergency department where my wife works as a nurse. She provided this EKG to me. You can see elevation up here in lead AVR and all of these different leads where there's ST segment depression. At 42 years of age, this guy was diagnosed with triple vessel disease and got a triple bypass. And he weighed about 165 pounds and was a perfect picture of health. You can't get past bad genetics. Here's another example. There's big elevation up here in lead AVR and multiple leads where there's ST segment depression. So just divide them as being sick and not heart sick. And treat the ACS patients as you normally would with aspirin and perhaps nitrates and pain relief, but also be advised, so I can talk on a radio, just remember that pattern can present in non-cardiac changes as well. All right, folks, that brings us to the end. At this point, if you have any questions, just hit me up in the chat box. There's my email address or handle. I'm very active on Twitter. If you follow me, I will follow you right back. If questions, if you want any EKGs just to look at, just send me an email. I'll gladly do everything that I have. But for me, and I look forward to talking with you soon. Bye.